Good morning to everyone. It's really nice to see a lot of familiar names and faces and be among friends. So thanks for having me. Like Raphael mentioned today, the talk is really, I tried to put a more sort of practical bend to it, and we'll really focus on OSA and its management. Oops. All right, cool. I have no disclosures. So objectives, first, we'll try to provide a pretty brief overview of OSA in the World Trade Center cohort. This is, I think, already very familiar to this group. Then we'll review some sleep testing options and diagnostic approaches to OSA. And then finally, the last portion of the talk will really focus on treatment options with an emphasis on PAP and PAP management. Just a really brief overview, as everyone is probably already familiar, OSA or obstructive sleep apnea falls under the category of sleep-related breathing disorders. The others in this category include sleep-related hypoventilation hypoxemia, as well as central sleep apnea and Cheyne-Stokes. Even though this is a very sort of large group of sleep disorders, there are several other types of sleep disorders that may coexist or sort of occur in individuals, and I just kind of listed them out as they're categorized in the ICSD, the International Classification of Sleep Disorders. So like our DSM-4. All right. So just really briefly, I think everyone is already quite familiar. The syndrome of obstructive sleep apnea is really characterized by repetitive cycles of airway narrowing and collapse that result in either sort of a total cessation of breathing or a reduction in breathing, or an apnea or hypopnea, which is all happening in the presence of ongoing respiratory effort. This then leads to arousals and sleep fragmentation, and can cause a lot of the sort of the typical symptoms and consequences that we traditionally associate with sleep apnea. I'll go over that in a later slide. So we also know that there's quite a high prevalence of OSA in the World Trade Center sort of exposed population. Globally, the prevalence of OSA actually varies somewhat by country, so it depends on sort of where you're looking and sort of which source you're looking at. The rates also somewhat vary depending on age, gender, and severity, and can range from the single digits to as high as the 70 sort of 80% range. So it really sort of depends on what you're looking at. Like I said, in the World Trade Center population, as we already know, there is a high prevalence of OSA. You'll see this paper, many familiar names on this on the author list of this paper. So in this particular paper, a prevalence of 75% of people having an AHI-4 of over greater than or equal to 5, so at least mild OSA. So really high numbers. The majority of patients tend to have mild, but there is a spectrum of moderate and severe patients as well. The paper also actually highlights the presence, as the name suggests, it really highlights the presence of chronic rhinosinusitis as an independent risk factor for OSA in the World Trade population. Other suspected contributing factors to sleep apnea in general, and in this population may include factors like BMI, so presence of obesity, and other mechanisms such as greater pharyngeal collapsibility, a difference or a lower arousal threshold, high loop gain. These are all sort of potential mechanisms that are still being explored. So that was sort of just a very brief background. Sort of moving on to the next phase of the talk to help sort of anchor the different topics that I'll go through. I tried to introduce a couple of highlight a couple of papers that some of which may already be familiar to the group, but these papers have been sort of very helpful in serving as a guide to the understanding and management of OSA. The first one is, I think Raphael also emailed this out to the group, comes from a series of best practices specific for the World Trade Center health program. This one focuses on OSA best practices. The The article below it comes from the American Academy of Sleep Medicine, and there's another sort of series of clinical practice guidelines ranging from sort of diagnosis to management. So these are two very good sort of resources to become familiar with. Okay, so first question, when should one screen or test for OSA? So technically screening or testing in asymptomatic patients is not recommended. It is, however, important to ask about sleep. And I think this is, part of the usual sort of history taking, especially in the WTC population as well. So symptomatic includes someone who complains of snoring, somebody who has daytime sleepiness, unrefreshing sleep. They may also report symptoms like cognitive impairment or memory impairment, and the patient may have comorbid hypertension. There are, in sort of general practice, there are several preoperative screening risk assessment tools. So these patients are not necessarily sort of coming to the visit with a complaint of sleep apnea or sleep apnea related symptoms, but because they are anticipated to undergo surgery, there are these sort of preoperative screening tools, one of which is the stop bang. This is sort of easy to remember, but there are a lot of other tools. People who are deemed sort of potentially high risk or intermediate or high risk should, go on to have sleep testing prior to their procedure. And then, in terms of comorbidities, this is also a very important sort of category to think about. If you, sort of see patients with certain cardiac, pulmonary, neurologic comorbidities such as, heart failure, resistant hypertension. In the pulmonary world, we think about it, in patients who have really poorly controlled asthma or airways disease. You see OSA can coexist with COPD in sort of this overlap syndrome. So, it is always recommended to sort of inquire about sleep in patients with COPD, especially the more advanced disease with sort of reduced lung function, and certainly people who, may be at risk for hypoventilating, but the hypoventilation is technically separate from the obstructive sleep apnea piece. You also want to sort of think about it in patients who have had CVAs or TIAs, so cerebral vascular disease. Also very important to sort of think about sleep apnea and potentially asking about sleep symptoms in patients who have comorbid endocrine issues such as diabetes, people who have hypothyroid, PCOS is very common, and obviously the metabolic syndrome. The hematologic sort of comorbidity is a little bit maybe debated somewhat, but we do see referrals, for this reason quite frequently for secondary polycythemia. Usually these patients will have mild polycythemia or erythrocytosis. And they do typically undergo sleep testing just to evaluate for any sleep apnea, but also comorbid things like hypoxemia and hypoventilation. Also very common sleep apnea can be described or has been described in patients with end-stage renal disease, maybe related to sort of volume issues, but certainly important to sort of ask about that. And then pregnancy is, I'll only say I won't go into more detail on pregnancy because I think that can be a whole separate talk on its own. But there's a lot of work and has been on, looking at sleep disordered breathing in pregnancy and sort of how to sort of diagnose and manage that. And, the final piece really goes without saying is, if we have any patients with critical occupations, and, I know we see a lot of that, especially in the WTC health program, so MTA workers who are drivers, or train operators, people who are pilots, commercial truck drivers. These are really, important sort of occupations to kind of think about and screen for sleep apnea. And obviously also includes a very important sort of safety counseling if sleep apnea is diagnosed. Okay. So here is the Epworth scale. I think this is probably very familiar to the group already, but it's a objective way to sort of quantify a subjective symptom of sleepiness. Technically, an Epworth score of greater than 10 is considered excessive daytime sleepiness. The the recommended sort of algorithm for evaluating or approach to OSA diagnosis. I put this up here, and this is what we use daily in our practice as well. So basically, you have a patient who comes in whom you're suspecting OSA because of either presence of symptoms, because they've been exposed to the World Trade Center disaster, or they have other comorbidities, or a combination of any of the above. So you start with a high clinical suspicion. And then, you go on to ask, does the patient have any major comorbidities? And the answer really has to be no in order for you to move on to home sleep testing. And I'll go over, sleep testing in a minute. But if the patient has any other sort of significant cardiopulmonary disease, or is at risk for these other more complicated types of sleep disordered breathing, like the hypoventilation, like the central sleep apnea, then really that patient would be better served undergoing an in-lab sleep study. And so sort of your decision point is, are we sending this patient to a sleep lab for overnight testing, or can we proceed with a home sleep testing? And then once the results of that test come back, if the home sleep testing is negative, and you're still, you still have this high clinical suspicion, because again, the patient was symptomatic and had all these other reasons for you to be thinking about sleep apnea, then that patient should really go on to have a PSG for further evaluation. And obviously, if the PSG, the overnight test, is positive, then we move on to treatment. So this algorithm, is really what's recommended by the AASM, as well as other sort of societies, in evaluating anyone with a suspicion of sleep apnea. Okay, so I mentioned I wanted to go over a little bit about sleep testing. So here it is. I think this picture is actually really funny, but actually very true. A lot of patients come back to us and kind of have the same reaction, like, how am I supposed to sleep with that? So that the picture is really alluding to the traditional sleep testing or polysomnography. So that's the in-lab sleep study. As you can see, it can be used for diagnostic, so for looking for sleep disordered breathing, but also for other types of sleep disorders, movement disorders. It's a part of the assessment of hypersomnias and narcolepsy, and it's really the recommended initial test of choice in pediatrics. So in babies and kids, those patients tend to it's the in-lab studies are preferred compared to home. The in-lab studies acquire a large amount of data. I put a picture here of all the different sort of sensors that we have. So it's true that there are a lot of things attached to the patient. We're gathering EEG, which is a very important sort of distinguishing factor between in-lab versus home tests. So we have the ability to measure sort of brain waves and score sleep based on the EEG. We also have the EMG, which measures sort of muscle activity and looks for helps to identify periodic limb movements or abnormal elevations of EMG signal, which can be seen in conditions like REM behavior disorder or their sleep-related movement disorders. And then patients have a modified EKG, so not a 12-lead, but it's a sort of a there's three sensors for a composite sort of single-lead EKG. And then we measure breathing through a chest and an abdomen belt effort. And then we measure actual breathing flow through a nasal cannula and an oral nasal thermistor. Obviously, we're capturing continuous saturation and plethysmography. We have the option of adding CO2 monitoring. This is not standard, but certainly can be included if there is concern for abnormal CO2 levels during sleep. And it typically is a single night test. So, it is unfortunately a snapshot in time. And if there is any concern for sort of night-to-night variability, that's a separate discussion on its own. But there are, some approaches or suggestions that, doing sort of multi-night may be more beneficial. More info to come on that from some of our research group. Okay, so that contrasts with home sleep testing, which is really geared, again, in identifying purely obstructive sleep apnea only in patients who have a high pretest probability. So if we think the patient has a high probability of having moderate to severe OSA, and sort of the different societies have kind of defined that, high pretest probability of moderate to severe OSA as people who have daytime somnolence and at least 2 out of the 3 of symptoms of snoring, witness apneas, or hypertension, who do not have, the other sort of major comorbidities, someone without heart failure, without severe COPD, et cetera. Home sleep testing actually has been around for, a couple of a while now, and it sort of continues to be evolving in terms of the equipment and devices that are available, but they've been categorized into sort of 3 different levels, and this is really based on sort of the intensity or the amount of information that's collected. So type 2s are sort of collect a lot of have a lot of sensors and collect a lot of information that they're sort of they've been also termed the unattended polysomnography. And then as the number goes down, the study becomes less complex in the sense that it collects less and less information. I've put a picture here of the WatchPat, which is a device that we use primarily here at Mount Sinai in our sleep program for home sleep testing at this time. And this is really a PAT, or peripheral arterial tonometry based technology. So it's really using sort of surrogate markers rather than direct measurement of flow and effort to identify respiratory events. But has been validated and is, fairly good in identifying, again, the most uncomplicated cases of sleep apnea. Okay, I threw this in here just because, this is a Sinai specific group, but a quick sort of guide to ordering within the Sinai system. If there's any confusion or when in doubt, just use sort of the CPT codes. So the code for the home sleep study is the 95800, and that again will get the patient a WatchPat. For in-lab, you have 2 options. You have a 95810, which is a diagnostic polysomnography. So this is a purely diagnostic test, meaning the patient is going to get a full night of monitoring. You want to specify sort of why you're referring the patient. So I suspect OSA, or I suspect the patient is having a parasomnia or nighttime seizures, and also indicate the need for CO2 monitoring. Again, this is not automatically added for all studies. The other option is a split or a PAP titration. This is where I think more of the confusion sometimes comes in. 95811 is any study that includes application of PAP. And you want to indicate if you're referring the patient for a straight sort of PAP titration, whether it's CPAP or bilevel or, other sort of modes of PAP therapies, or any positive airway pressure, or a split study, which is, I think, the most confusing option is basically a split study means the patient has a part of the night getting sort of diagnostic monitoring, no intervention, and then part of the night on PAP or on some sort of intervention. It doesn't have to be PAP. It could be, actually, it technically has to be PAP. But, you could send a patient in for like diagnostic and or appliance efficacy testing, for example, but you wouldn't use 95811. So 95811 is if you're referring a patient for, and you want to do a split for part diagnostic, no PAP, and part of the night on PAP, and you want to, most importantly, sort of specify the criteria for moving the patient over from the diagnostic mode to putting them on PAP. The lab standard is to do that for patients who meet the AHI 4 over 30, but the patient has to really do that or show us that the AHI is going to be over 30 in the first 2 hours. If the patient sort of meets that AHI later than that, then we really don't have time to do a full titration. So then, that patient will probably end up not being split. So if there's any other sort of questions about sleep testing and ordering, happy to field that later. Obviously not the main goal of today, but I wanted to include it. And then lastly, to indicate any special needs, patient who's non-ambulatory, has any, sort of visual or auditory impairment, patients who need home oxygen. So it's sort of good to know, who this patient is coming into our lab for testing, and make sure we're adequately prepared. Okay, this is what, so after the patient gets a sleep study, this is really what the data looks like when we sort of review and look at sleep studies. So sleep apnea as seen on the PSG. I know there's a lot of lines here, just but basically just to kind of orient everyone, the top half of the screen here is should be a 30-second window. And then the bottom half of the screen here, here I have it on a 5-minute window. And basically this is what an OSA or obstructive sleep apnea event looks like. As you can see, the patient has had several of these. These are the side sort of is the indicates what channels, but the top three here are EEG. The blue is the eye movements. This line is the EMG. Here we have the breathing sensor, and then we have the EKG. On the bottom, we have the leg EMG. This is the chin EMG. And then we have the 2 respiratory efforts, a snore channel, 2 measures of airflow, saturation, and the pleth. And so again, the OSA event, in this case, an apnea, you can see this patient had a period where there was a drop off in the flow in the presence of ongoing respiratory effort associated with a pretty significant desaturation. There's also arousal. So this event then goes back that will then be scored as an obstructive apnea. And as you can see, this patient had pretty repetitive back-to-back. So that's what OSA will look like on a PSG. This is very different from, or kind of different from what OSA looks like on the WatchPat. Again, just took a quick snapshot, but like I mentioned, the WatchPat, is very different from the sleep from the PSG, where it does not monitor breathing. So there's no nasal cannula. So instead, what the algorithm does is it uses sort of surrogate physiologic markers of arousal. And there's a sort of a proprietary algorithm based on what is going on with the PAT or the peripheral arterial tonometry signal, and the sort of snoring and movement and some qualitative assessment of the respiratory effort, that chest sensor that patients wear. And it will identify events based on that. So it generates an index of severity, but again, it's not based on direct measurement of the absence of flow or reduction in flow. It's rather the physiologic arousal that happens secondary to a respiratory event. So circle that right here. This is what the algorithm usually look at. If it sees this, it will say, oh, this patient probably just had an arousal from a immediately preceding obstructive event. So that's what the data looks like. And we do look at all the raw data for both home and in-lab tests to make sure that we agree with the scoring and then generate our reports. So just a word on OSA severity. There's a bit of a terminology soup going on. There's many different ways. There's a few different ways for us to describe the frequency of respiratory events, but the traditional is that apnea hypopnea index, right? The AHI, and you guys have all seen this on your sleep study reports. So this is the total number of apneas plus hypopneas divided by the total sleep time as measured by EEG. So on the on an in-lab or PSG study. If we have a home test, for example, where we're really not measuring the EEG and we don't have a true assessment of total sleep time, then technically that index is termed the respiratory event index, or the REI. And then PAT-based devices such as the WatchPat will generate the indices are also termed AHI and RDI, which in this case stands for respiratory disturbance index, which I didn't include just for the sake of sort of simplifying. But the indices are always denoted by a little p, so you know that if it's a PHI, this number came from a WatchPat and not an in-lab sleep study, for example. And then the categories of severity are as follows. I will not sort of go into the 4 versus 3A AHI sort of discussion here, but for the sort of sake of generalization or for this talk, the severity categories are, an AHI of under 5 is considered normal. Mild is 5 to less than 15. Moderate is 15 to less than 30. And then severe is an AHI of greater than or equal to 30 events per hour. Okay. So that was sort of the diagnosis and a little bit on sleep testing. And now I'm just going to time check. Okay. I'm going to move on to the last portion of the talk, which is really to focus on treatment options. And I'm sorry if the preceding slides were a bit of a review, but this is all leading up to the treatment part. So some options and approaches. All right, so your patient has, completed sleep testing, has, confirmed your suspicion that of OSA. We have either had done a home test or an in-lab study, and we have a sense of what the severity is. So what next, right? I do want to highlight another, all of them kind of look the same, but this is another ASM practice guideline. This one specifically is on the treatment of OSA with positive airway pressure. It's actually a really helpful read. So if you guys have time, I would highly recommend looking through that if you haven't seen it already. But PAP is considered still considered first line or sort of the one of the standard treatments for OSA. And I know PAP is very familiar to this group. For the vast majority of patients who are diagnosed with uncomplicated obstructive sleep apnea, so no like weird centrals on the sleep study, no evidence of like sustained desaturation or sustained hypoxemia. For those patients, for an initial start with auto PAP is most likely going to be fine. The usual settings are when we order auto PAP, I usually do 4 to 20, which is the entire range. You can certainly narrow it depending on the clinical situation and the patient. And then when we're initiating auto PAP, we do prefer to have the patient use nasal or nasal pillows. I'll go into this in a little in a subsequent slide in more detail. The key again to, starting any patient on PAP is really to follow up, both to monitor compliance because of some of, depending on the patient's insurance, unfortunately, sort of the compliance monitoring guidelines, Medicare, for Medicare patients, they really need to be seen within 31 to 90 days, so within the 3 months of starting PAP. And then also to sort of assess patient response and tolerance of therapy, and then, to counsel about safety, driving, etc. You should consider doing a PAP titration, however, if you have a case of complex sleep disorder breathing, so somebody with potentially mixed centrals, hypoventilation, in patients who have other comorbidities that predispose or increase their risk of having central or PAP-induced centrals, for example, or who may just have more complicated sort of sleep disorder breathing to begin with, like patients with heart failure, patients with a lot of periodic limb movements, patients. This is a little bit of just anecdotal practice, but sometimes like very anxious patients, they may benefit from like going to the lab as long as they're willing to, but like they meeting the tech and kind of getting an in-person mask fitting, and then sort of experiencing one night with PAP, knowing that there's like a technician right outside who can sort of provide some counseling or answer some questions or kind of do some sort of explaining during the night if they experience any issues. And we see this a lot, and we do this a lot. Our technicians will kind of walk patients through if they have claustrophobia, if they can't tolerate the pressure. We can change masks during the night. We can add things like a chin strap. So it's, it may help with if you have particularly anxious patients who are interested in trying PAP. And then obviously, again, for, hypoventilation, anybody who needs to add oxygen to their PAP therapy, these patients really should be coming back for PAP titrations. Here I just went ahead and summarized the recommendations from this particular practice guideline on using PAP. And again, the strong recommendations are to use PAP compared to no therapy to treat OSA in patients with excessive sleepiness. So again, if your patient is symptomatic and has OSA, consider starting with PAP. And then they say either APAP at home, auto PAP, or in-lab PAP titration to initiate PAP in OSA with no significant no significant comorbidities, to continue to use PAP for ongoing treatment, and then to provide educational interventions at the start of PAP, to help with their understanding and to hopefully improve their adherence. They also suggest using PAP compared to no therapy in patients who may have not necessarily sleepiness, but just impaired sort of sleep-related quality of life. People who have comorbid hypertension. We prefer to use CPAP or auto PAP compared to BPAP or bilevel in the routine sort of treatment of OSA. Again, obstructive sleep apnea without comorbid sort of hypoventilation, hypoxemia. And then, they also put in sort of suggestions about behavioral interventions and potentially using telemonitoring during the initial period of PAP therapy to again, help with adherence and compliance. Okay, so what happens when a patient actually gets the PAP sort of set up or delivered to their home? It's the different components of a PAP setup include obviously the device. This is just a picture of the three sort of common devices on the market. This is the ResMed, this is the Philips Dream Station 2, and then this is the Luna 3B machine. And so we have the device, we have the tubing, which connects the device to the mask. And then we have three different types of masks, but within each type, there are many different models. So you have the nasal pillows, you have the over the nose, and then you have the full face, which covers the nose and the mouth. In addition to tubing, patients will need supplies like filters, which needs to be changed out every month. The water chamber, which contains the, in which patients put distilled water for humidification purposes. Here's a sample of what a typical sort of prescription for auto PAP or PAP should include. So obviously you want to put in your PAP mode and your settings, whether it's CPAP or APAP or bilevel. I don't usually specify the brand of the device, unless the patient specifically wants one particular brand. You want to include the mask type and the size, or you can say something like best fit, if you don't know the specific mask that the patient needs. And then you want to sort of type in a refill allotment for supplies and how frequently it's refilled. A diagnosis is important. The diagnosis of OSA is G47.33, as I'm sure everyone knows. And then you want to include the provider name, license number, and NPI. And so all this can, this information then gets sent off to the DME, and the patients can be set up with their devices. So I'm going to go on to talk about, once the patient has been put on PAP, what now, right? So number one, we all sort of know that it's important to have the patient come back for like the compliance visit or for the download. So I'll go into, I'll have some samples of what the PAP data looks like. But in general, to get the information from the PAP devices, you can either download it from a modem or a wireless transmission. So this is the device sending it to sort of the specific manufacturer cloud-based system, and then you can download or log into the system and look up the patient and download a specific time interval for the data. You can also get the data direct off the SD card, which not all machines, the older machines would have the SD card. Not all patients always have an SD card, so it's important to check and ask the patient. You can also actually look for most of these devices. You can look at the machine itself. It may not necessarily give you sort of the entire as full of a range as if you were to log into AirView, for example, but you should be able to at least look at, you'll be able to get some information about the recent compliance and settings on the patient. And that's what sort of this picture would look like. Different ways of getting into this on different machines, but we have done that on occasion in the office when we couldn't get the information from any other way. Okay. So I'm just gonna, next couple of slides, just gonna run through a couple of the samples or downloads from the various companies. So here, we have the summary view from the Philips machines. And essentially we see in this particular report, we have a month's worth of data. You can actually, they allow you in Care Orchestrator, and that's the sort of the cloud system that Philips uses. You can specify your time intervals. So you could do 3 months, you could do like 6 months. I think it's up to a year. Of data that you can sort of look at one time in summary. But in this in whatever time interval view, you'll in your summary report, you'll have the date range, so 30, 60, 90 days. It will tell you how many days the patient has used the device, how many days without device use, and then it also give you the average usage statistics for all versus on the days that they use. So in terms of number of hours and minutes, and then the important thing for most sort of insurance carriers are that 70% rule, right? So this is it will tell you the percent of days with usage greater than or equal to 4 hours, and you have a percent right there. It will also sort of show you the settings on the machine here. The min, the maximum. In this case, the patient has an auto CPAP set between 5 to 15 centimeters of water. The AFlex is sort of the Philips version of the when pressure drop on patient sort of exhalation. That's more of a touted as a comfort feature. You can also see what the ramp settings are, whether it's on or off, and how long the machine takes to ramp up. So ramp is it'll start at a lower pressure and then kind of slowly build up to the treatment pressure over some period of specified time. And then it will also tell you what the machine is doing, and what the residual sort of average AHI is. So this, this information is very important. We look at this. It's a big area of our focus on our follow-up visits, because we want to sort of see, how much pressure is the machine sort of giving the patient, just to sort of document, or sometimes we use it to troubleshoot. I'll go into that. I'll go into a little bit more detail later. And then we want to look at sort of what the residual amount of events is. If this is sort of greater than 5, which is below 5 is under the goal, then we need to sort of troubleshoot and think about why the machine is sort of inadequately or not fully treating the OSA. So this is a summary view. You have, they also give you sort of graphical summaries of humidification and the hours. And then, so that was Philips. This is what ResMed looks like. Again, same information, just presented differently, slightly different graphs. But again, you have the time interval, you have the usage, 4 versus under 4, you have the machine settings, and then you have sort of information about how the therapy is going, what the pressure ranges are, what the leak is, and then what that residual AHI is. And they also have, give it to you in sort of a graphical form for the interval that you specified. So that's a summary view. If you want more details, you can actually go, download or get a sleep detail or a detailed summary. So this is going to really drill down and look at, you could even get like a day-to-day report on these machines. So this is what the sleep detail looks like on Philips. It will show you patterns of use on different days. So it gives you the time. The black is where the blower, the blower's on, but the patient's the mask is not on the patient's face. The green is when the patient is actually using it. So you can get a sense of, the period, the hours during the day when the patient is using it, as well as sort of a little bit of the duration based on the length of that bar. You can look at sort of what the pressure is doing over the course of, again, that, that in the interval that you're looking at. Displayed graphically, you can see what the AHI is on a day-to-day basis. This is the average, but you can sort of see on a day-to-day, how that average was achieved. And so lots of additional details. So we'll use this sometimes, in patients who have that high residual AHI to kind of help us figure out maybe some potential areas to adjust settings before sort of sending that patient off to a PAP titration. So like I mentioned, you can also do daily details. So this is looking at the data from a specific day or night. And so in this case, the x-axis here would be the hours of sleep. And then you can, it'll show you the different, what the pressure was doing, where the machine sensed that there were events or residual events coming through, which then contributes to that daily AHI number, and then the presence of leak. So again, we use these graphs to really go into some more, do a little bit of investigation and trying to solve the puzzle, in a way of why the patient's AHI is elevated. If there's no clues from these graphs or these reports, then, unfortunately, the next resort for a patient who's coming back with high AHI is to then send the patient off for a PAP titration. This is what the ResMed report, the summary looks like, or the detailed rather. So again, it's just presented differently. ResMed likes to use a different sort of color scheme, but really the same information about the patterns of use, the hours, the leaks, what the pressure is doing on a day-to-day basis, and what the AHI is doing on the day-to-day basis. Again, this is the detailed version of the report, so you get more of a daily data as opposed to just summary for the entire month. And this is what the detailed report on ResMed looks like. They give you a different type of graph. And you can also look in more detail about things like leak, which becomes important when we're dealing with not only just high AHI, but also issues of adherence. So I didn't, 9:45, okay. I will have to speed up. But I'm happy to, come back or, offline can go into do more of like workshops on how to sort of invest in more detailed look at these reports. But in general, so this is like the options of information that sort of is out there when you do a CPAP download. In the last couple of minutes, I just wanted to quickly go through. So, I know adherence is a big issue, for all. We're all familiar with the CMS, the definition, which actually, was instituted in 2008. So according to CMS, for Medicare beneficiaries, in order to qualify for long-term PAP use, they require the beneficiary has to use the PAP for more than 4 hours, or 4 or more hours per day for 70% of days over a continuous 30-day period. So it's not necessarily in the first month, but it's just any continuous 30-day period within the first 90 days of receiving the machine. And then you have to meet that requirement in order to continue coverage, long-term coverage of that machine. This rule has, been adopted by most large insurance carriers across the U.S. But there is, there are, I'd say there's various movements and sort of sources that are that may be advocating for sort of changing this in the future. So we'll sort of remain. We'll have to see sort of what policy changes happen. But take the VA for example. The VA does not follow necessarily CMS rules, right? The VA recommends continuing therapy even if the utilizer is using PAP for less than 4 hours a night. If there's any benefit or any sort of symptomatic improvement at under 4 hours. And then obviously, the WTC program has its sort of own set of coverage requirements, which I just took this from the medical coverage determination. I will not repeat this to the group, as I know you guys are all familiar. But I just wanted to kind of point out that the definition of adherence is unfortunately somewhat arbitrary, right? Where the 4-hour rule came from, potentially it was first described in this paper in 1993, and they literally say by Cribs, and they literally say this paper described a threshold of, quote, regular PAP use for 4 hours per day on the basis of what is known about the need for sleep, and 70% of days monitored determined by expert clinical opinion. So it's really not necessarily evidence-based, this 4-hour rule. There was a study from the Weaver group in 2007 that looked at severe patients pre and post 3 months of PAP therapy. And they did see significant improvements in sleepiness at 4 hours. But they also did note, I took this table from that paper, that there was a continued linear improvement with increased hours of PAP use. And there was improvement seen even at the 2 to 4, more than 2, but less than 4 hours. So, I think this information, as well as sort of, practically what we've experienced in terms of challenges in taking care of patients and getting them to quote unquote be adherent or compliant with PAP therapy, has led to a lot of this growing movement of potentially advocating for change. In the interest of time, I think I may not be able to go into a lot of detail, but this is a recent statement from the American Thoracic Society, a call to really move towards more equitable care for sleep apnea in the United States. Is relevant for even populations like the World Trade cohort, because what we sort of know about PAP adherence is that there's a lot of variability across race, ethnicity, and socioeconomic status. And so, even in these studies done out of VA populations, for example, where the entire, all the therapies were sort of, and supplies were paid for, so there's no cost issue, there was still a high sort of variability in PAP usage. And traditionally, lower adherence is always reported in patients in communities with a high proportion of Black, Hispanic, and Indigenous residents compared to white communities. And this may be due to, the paper actually summarizes really nicely, just the potentially sort of contributing factors, including poverty, unemployment, homeownership, noise, health literacy. So lots of components that contribute to why patients may not be as quote unquote compliant. And because of that, it really generates this like negative effect, right? Where, patients who may be socioeconomically disadvantaged are less likely to meet, CMS or other insurance sort of PAP adherence requirements. And because of that, they lose therapy, which may be helping them, symptomatically helping them, but that also creates, greater mistrust in the healthcare system. And, we're really, not necessarily sort of helping to improve the health and well-being of patients, in addition to potentially widening these healthcare and treatment sort of disparities. So a lot of policy implications in this single question of like PAP adherence alone. But I just wanted to bring the group's attention to this is a really, I think, really well written and an informative read. So if you guys have time, I'd highly recommend taking a look. Okay, so what can we actually do to improve PAP adherence? Two other guideline recommendations, one from the VA, the other was a meta-analysis from the AASM that really kind of goes through the data on the various sort of interventions that have been suggested or used in the past. But things that tend to work are, one, ensuring the patient has a correct mask, two, using heated humidification compared to no humidification, and then three, doing educational, behavioral, and like troubleshooting interventions, both to help patients understand why they have, what is OSA and what is treatment, what is it doing, to potentially include some cognitive behavioral therapy in addressing views on sleep, promoting positive associations with PAP, eliciting the support from, the patient's bed partner or home. Also, you want to address leak and make sure you have regular follow-up. So to kind of continuously review how the patient is doing and address any potential issues. And then potentially, although I think the data on this is not is ongoing, you want to address issues like high nasal resistance, so potentially with either nasal sprays and or sort of nasal interventions from ENT. I won't go into this in more detail, except to say that unfortunately, leak, which is obviously can be a big issue and cause, problems with adherence and tolerance of PAP in patients, is actually measured very differently depending on which brand of machine. So it's important to sort of know which brand you're looking at, and to interpret that leak number specific to the brand of the machine. And in the leak, there's always an intended leak. The intended leak really depends on, the type of mask the patient has. So I'll just kind of leave it at this, but happy to kind of go into more details offline. And then I think this is like the towards the end, I just wanted to put up some sort of CPAP troubleshooting in case like patients sort of come to the practice and have questions. So common complaints, dry mouth, nasal irritation. You really want to make sure the mask is fitting correctly. You can consider using a chin strap if the patient has a nasal mask. Again, use a humidifier, and then trying medications that help with the underlying cause of congestion. So like nasal rinses, nasal sprays, making sure the patients are cleaning their machines appropriately. Some patients may complain of aerophagia, which is this like sensation that, pressure is too high and they're sort of swallowing air. Again, number one, make sure the mask fit is appropriate. Can maybe, in select cases, consider changing the mode from CPAP to bilevel, or just kind of adjusting the settings, trying auto, trying to lower the CPAP pressure, really trying to address patient anxiety and making sure they're comfortable when using this the CPAP, and then question mark on the EPR or C-flex, which is the expiratory pressure relief, or essentially the pressure sort of drops a little bit on CPAP when the machine senses that the patient is exhaling. A lot of patients complain of difficulty sleeping and difficulty tolerating pressure. Here we really recommend, daytime desensitization. So bringing patients, you can have the patient sort of wear the mask and have the machine on sort of for 20, 30 minutes during the day. You can try things like, adding a ramp or lengthening the ramp to kind of have the pressures to build up slowly, and then continue to reinforce things like sleep hygiene and relaxation techniques. Another common problem that patients will complain of is this condensation in the CPAP tubing or the rain out, which is condensation that builds up when you have warm humidified air that flows through cold CPAP tubing. So people will say that there's like water in the tube, or it's like sort of flowing into the mask. So things you can advise are to change to heated tubing, to insulate the tube, try to increase the room temperature. Again, it's that the temperature drop or the differential between the ambient, the tube, and the air that's coming in through the tube. You can also advise patients to put the PAP machine itself below the level of their head, so under lower, and then to obviously to reduce the humidity setting if the patient can tolerate. And then lastly, just to kind of go back to the leak again, this can be patient reported. This can be on the download. They can say that they have dry mouth. They wake up, sometimes patients will say they wake up and they're like, their mouth is, feels like it's sandpaper. You can try things like changing the mask, adding a chin strap, really, I think, focusing on making sure the mask is the right fit and size for the patient, cannot be sort of overstated. And then if needed, you can adjust the pressure settings and lower the range. And lastly, just some practical tips for, the PAP download. So number one, when you have your patient come back, you want to check the total usage. Are they meeting the specific sort of adherence criteria that they need to be? And if no, why? Again, discuss with them what are the issues, what's bothering you, and then try to address those independently. This is kind of what I do in the office. And realizing that we don't necessarily have like 3 hours to spend with each patient, but you want to identify the patients with, major issues, and, identify whether these are issues that can be immediately intervened upon or that require, patients to come back for further testing. Then, you review your device settings. What mode are you on? What pressure range? Is the AHI within the range? And then if it's less than 5 and the patient's comfortable, you're pretty good, right? If the AHI is more than 5, again, looking through the details, considering looking at the daily download, and then kind of incorporating that with what the patient's experience is, because if they say that like when I'm sick, this is not working, then obviously, or I've been sick for the last 3 weeks, that's a very different situation than if the patient says this is sort of my health baseline, but I continue to have difficulties per night, every night with PAP, and it's because the pressure is too high or because I wake up and my mouth is too dry. So really trying to understand what is challenging for the patient. And if you're not able to determine an obvious cause and solution, then certainly consider sending that patient for a CPAP titration.